We're going to talk about the treatment protocol that I have ongoing in Denver, Colorado. I've now been in Colorado since 2001, so 18 and a half years. That amazes me because I thought I was a Boston girl and I was there for 17 years. I'm going to explain to you about my antioxidant protocol, which has really been going on now for 10 years plus, and explain to you why I'm doing this treatment and what we have seen in the patients with Smith-Lemli-Opitz who I've been treating so far. So I have been a physician now for almost 40 years. That's a scary number. And so I cared for patients with Smith-Lemli-Opitz really since the mid-'80s. And then in 1994, I was fortunate enough to be one of the people who helped discover the cholesterol problem in patients with Smith-Lemli-Opitz when I was at that time practicing in Boston. And so for all of these years, 25 years, I've been giving people cholesterol and learning from my patients and trying to understand all the different medical problems and developmental issues that they have had. So in my experience, one of the problems that was obvious to me and to my patients and their families was that many of them had problems with their vision. And when they went to the eye doctor, they had abnormal vision, and they had abnormal findings when the eye doctor looked in their eyes, both just looking on the outside of their eyes and also looking in the back of the eye in the retina. And I was fortunate to be working with excellent pediatric ophthalmologists who were able to get really good looks in my patients, a little bit tricky sometimes. But what they noticed was really two things. The vision seemed to get worse over time. So patients that started out with some visual problems, as they got older, their eyesight became worse. And when the eye doctor looked in the back of the eye, there were deposits of pigment that were abnormal and got worse and worse over time. And there's a very specialized eye test called an Electro Retinogram, or ERG for short. And when we did that very special eye test to look at the function of the retina, the back of the eye, we were able to see that the function of the retina became worse and worse over time. And that correlated with the vision becoming worse and worse over time. And I became particularly interested in this when one of my patients that I followed the longest, a girl who's now in her 30s, she was the patient whose picture was in our New England Journal of Medicine paper in 1994. So I've been following her for a very long time. By the time she was a teenager, she was blind. And I also followed her mother's cousin's child had SLO2. And when that happened to this patient, I looked at all my other patients much more carefully and started to follow them much more carefully over time with the ophthalmologists. And I was able to see that over time, even though they were all getting cholesterol, the changes in their retinal function were getting worse over time, and the pigment deposits in the back of the eye were becoming more pronounced. When we actually did this special test, this Electro Retinogram test, there were two things that we looked at that you can measure. You shine light in the back of the eye, and this special machine, you have a contact lens in the eye attached by wires to a machine, and the machine measured that. It took a greater amount of stronger light for the retina to react, and that reaction took longer to happen than normal. So the reaction itself was too small, and the amount of time that it took for the reaction to happen was too long. And you can measure those things very, very objectively. It's not just, I think it looks a little worse, but actually it's a number, a numerical result that you could follow over time and show that things were definitely getting worse. So I just wanted to talk for a second about the two main kinds of eye cells that there are in the retina. I think you probably heard about them since elementary school, rods and cones. Everybody remember hearing about rods and cones? These are cells in the back of your retina, in the back of your eye. They're called photoreceptors because what they do is they take light from the outside and they modify it and send the impulses to the brain so that your brain can understand what kind of something you're seeing. So in your eye, there are somewhere between 5 and 7 million cones, but many, many, many more rods than cones. So something like 110 to 130 million rods in your eye. So the cones are mainly in the middle central part of your eye called the fovea, and rods are found mostly in the outer part or the peripheral part of the retina. And if you look at the difference in shape between rods and cones, the rods are long and sort of skinny, and the cones are shorter and wider. And when you look at the bottom of the rod cell, I'm not sure this is, whoa, no, go back. I was trying to get here. If you look at the bottom of the rod cell, you see those lines there? Those are all discs. And there are hundreds and hundreds of discs in each rod cell that are made out of lipid, cholesterol, okay? So if your cholesterol level is really low, it's going to be very super hard to keep making more rod cells. And the retina is one of the places in the body where cells turn over the fastest. So if you have SLO and cholesterol deficiency, it's just not possible to make as many new rod cells as you need. And in fact, the rods are the cells that are most impaired if you have SLO. So this is a picture of what the Electro Retinogram shows us, and you can see this response in this wave, and we can measure the time it takes. It's called the latency time for this wave to form, and how tall the wave is, and that is called the amplitude. And so that's what we're actually measuring when we do the ERG test. And the waves from rods and cones look different, so we can tell the difference that we're looking at rods and cones on this test. So there was some very, very interesting research in an animal model of SLO. There's a very brilliant scientist named Steve Fleisler, and Dr. Fleisler was studying the retinas in mice and rats who had Smith-Lemli-Opitz. And he was actually able to see the same changes, the same abnormalities in his animal model on this little teeny tiny ERG that I was able to do in a rat that I was seeing in my children and my human patients. But in animals, you're just able to try different medicines and try different things to try to correct an abnormality. So in his animals, he discovered that if he gave the animals certain vitamins, that it could help turn around and correct the abnormalities in the animals that he was seeing. So he called me up and he said, Ellen, you gotta put all your patients on vitamins. It took me over a year to get permission from the FDA to do that because I was still using an investigational new drug number to treat my patients with cholesterol, and so I had to get permission from the FDA to change my protocol. But finally, by 2008, I was able to add vitamins to my regimen. So I give cholesterol plus vitamins. And I've been able to study the ERG test, this very specialized test of retinal function, and also do a good eye exam under anesthesia. That's what EUA stands for, an exam under anesthesia with a pediatric ophthalmologist. So I would bring my patients at baseline. I'd get a set of ERG values using that special machine, and then I'd have the eye doctor go in and get a look at the retina and take pictures of what the pigment deposits looked like. And then I'd start the patients on a special kind of vitamin, and then I'd follow them, and every year or two, I'd bring them back and do the studies under anesthesia again. And I've been doing that now since 2008 in my Smith-Lemli-Opitz patients. We have a special camera called a RetCam, a retinal camera, that can take amazing pictures of the back of the eye, and so that we can actually see what the retina looks like and follow the changes in pigment. So remember, before these pigments, you'd look at every year, and there was more and more and more pigment. And the eye function measured by how well the kids' vision was tested, and also on the ERG would get worse and worse and worse over time on cholesterol alone. So the vitamin preparation that I used up until this past January was called Aquadex. And the reason that I picked Aquadex is that Aquadex has lots of different vitamins in that preparation, including lots and lots of different vitamins that had antioxidant properties. And the company that was making Aquadex at the time, 10 plus years ago, they gave me the Aquadex for free. We had it by the buck and load in my hospital because my hospital was one of the sites that showed that Aquadex was safe to use in children. So I had it for free, and that's why I used that preparation. That company went under, and so I had to find a new company that's making a similar preparation. And so the new preparation, which is very, very similar, is called DCAS Plus. So that is what I'm using now. So the information that I have to report to you was on 25 patients who have Smith-Lemli-Opitz. This was confirmed biochemically and genetically shown that these children had mutations. And I was treating them in my hospital, Children's Hospital, Colorado, starting in 2003, before I had Aquadex, and continuing through now. And these 25 patients have all had at least one eye exam under anesthesia, EUA, and an Electro Retinogram, ERG. And I have the benefit of seeing what the patients looked like before they started on the antioxidants, and then since 2008 on both medicines. The average age was 10 years, but ranged from very young infants to adults. So when I'm trying to assess how severe a patient's Smith-Lemli-Opitz is, one of the ways that I have decided to think about that is using something called a sterol ratio. In the old days, we had a severity score that was based on how many birth defects a patient had. And that was sort of heavily weighted to males who had genital abnormalities and wasn't as helpful maybe, or at least in my mind, as this way of looking at it biochemically. And I take the amount of precursors, adding them together, the 7 and 8 dehydrocholesterol, and divide it by the cholesterol level and multiply by 100, and that gives me my sterol ratio. So the higher the level of precursors, the more severe the disease, okay? And so I've just made a division that if the ratio is up to 3.5, I'm calling that mild, and from 3.6 to 17, moderate, and severe is greater than 17. And it's important when you're doing this ratio to understand that cholesterol levels and precursor levels are different units when you get the results back from the lab. So you have to make sure you're converting it into the same unit to make this ratio. So here are the results, and I've updated these through this past year, 2019. So I have 7 patients who have had at least one ERG. And of those 7 patients, the mild patients showed both increased time to show the reaction, and this was seen in rods and cones, but the rods are worse. And the rods showed a mild to moderate change in how high the wave is, and the cones were sometimes normal or had a mild change. And then in these patients, 4 of them had more than one study, and I was able to show that they all had an improvement in the waveform and a decrease in the amount of time it took. And on their exams under anesthesia, there were 2 patients who had mild pigment deposits that got better. There was no worsening of the pigment deposits. And then in one of these patients, the eye doctor described that the eye nerve looked very small and had abnormal pigment. Of the patients I was not able to follow up, one of these patients died of an unrelated accident. 3 moved away and were lost to follow-up, and 1 just recently enrolled, so I just have 1 data point. Of my moderate patients, there are 11. All of them had abnormalities in both rods and cones, but again, the rods are more severely affected than the cones, and the severities seen in both the rods and the cones were more obvious to see more severe than in the mild patients. There are 8 patients that I have with serial studies. 6 improved and 2 were stable. No one got worse. In terms of the exams under anesthesia, there were 4 patients who had pigment deposits that improved. There was nobody who had worse in their pigment deposits. 2 of these patients had very small eye nerves, and 1 had unusual vessels. And in this group, 1 patient developed a cataract and severe retinal detachment. Of my severe patients, I had 7 total, 6 with at least 1 ERG and follow-up studies. All 6 severe patients showed this time to show a reaction. The implicit time was increased, and the amplitudes in rods, again, were worse than cones. What I think is totally weird, and I don't have a good answer why, is that the cone amplitude seemed normal in these severe patients. I'm not sure why that would be. There are 3 patients in this group who had follow-up studies, and the rod function sort of got better in some or stayed the same in some. Cone function was stable. There was nobody who lost vision in this group. And so this was the group that before there was antioxidants, their vision was getting worse and worse over time. And 3 of the patients showed stable pigment deposits. There was no progression or worsening of the pigment deposits, but I also didn't see any improvement in any of these very severe patients. And one patient showed very severe hypopigmentation, so the retina looked very, very pale. It's very unusual. So to summarize the Electro Retinogram findings, my patients with Smith-Lemli-Opitz demonstrated this abnormality on EARG, so it takes a longer time to show the waveform no matter how severe the disease is. And the rod cells are more impacted than cones. And again, I showed you why I think that is, because rod cells have a lot of lipid in them, and you can't make new rod cells if you are very cholesterol deficient. And the cone cells were normal in very severe patients, and I really don't have a good answer as to why that is. And on patients with treatment with both cholesterol and antioxidants, I do that together, now using the DCAS Plus medicine instead of the Aquedex. I was able to demonstrate improvement in this objective test in amplitude, implicit time, and patients were either better or stable, but no patient had worsening retinal function on the antacids, which compared to my historic controls prior to the use of antioxidants is an improvement. This is just a picture, one of the RetCam photos to show from one of these patients, and the sort of increased blackness around the edges is what this pigment deposit can look like. Looking at the findings under anesthesia by my wonderful pediatric ophthalmologists, these pigment deposits were seen no matter how severe the disease was, but in my milder patients and some of the moderates got better, and in the severe patients was stable, and no patient got worse. So I feel like this has been a clinical improvement. Now, the science of this has helped me understand better. So we know now that 7-dehydrocholesterol and 8-dehydrocholesterol, these precursors which patients build up, are oxidized, have this chemical reaction 200 times more easily than cholesterol because of that extra double bond. And so when they get oxidized, they're turned into chemicals called oxysterols, which we know now from studies by my collaborators in the lab can cause death of brain cells, neuronal cells, death of retinal cells. These oxysterol toxic chemicals can impact your skin, your liver. They're very, very toxic compounds. And so by giving antioxidants, preventing that oxidation reaction from happening and hopefully decreasing the amount of oxysterols. I'm collaborating with a very smart scientist who works in Seattle. His name is Liban Zhu. And Dr. Zhu is able to actually now measure oxysterol levels, which we haven't been able to do up until fairly recently. So I don't have that data yet to report to you because he is still working on that assay, but he has collected blood from my patients to send to him so that, and it's frozen away in the lab, so when this assay becomes easier to do, I'll be able to also follow oxysterol levels and figure out, am I giving enough vitamins? How can I make this better, and which vitamins. I'm giving at least 6 different antioxidants to my patients. Is there one that's better than another one? Can I just give vitamin E alone, and will that do the trick, or do I have to give all of these things together? I don't know the answers to that question yet, but we're trying to work on that and understand it better in the laboratory, and I am collecting blood for oxysterol levels that we will be able to eventually have that those results for you. So now I think I can understand why and understand the science of why antioxidants are helpful. I wanted to give you a little bit of data about the hearing tests that I've also been doing in patients at the same time. And this data was pulled together by a very smart initially medical student and now pediatric neurologist, Tiffany Poynton, who continues to work with me on this project. So we used a special test to analyze hearing status in patients with SLO, and we were trying to determine, could we see a similar effect of antioxidants in the hearing pathway that I was seeing in the visual pathway, because that very smart scientist, Dr. Fleisler, was also doing this in his animals, and he thinks that the hearing pathway also improves with antioxidants. So we looked, the test that we did to do this is called an auditory brainstem response, or an ABR test, and that measures 5 waves going from the ear, when sound hits the ear, all the way into the deep part of the brain where your hearing center is. And what we were trying to measure was the difference between wave 1, when hearing stimuli first hit the ear, and wave 5, which is the deepest wave that we can measure, and measure that amount of time between wave 1 and wave 5. So we looked at patients have 2 ears. So we have 2 sets of data for all of our patients, just like we have 2 sets of data in each eye. There were some interesting things that we saw in this study. So about a third of our patients had this prolonged wave 1 to 5 interval, but amongst those patients, there were patients there that actually had normal hearing. So there wasn't great correlation between what we saw on the ABR and actually how well the child was able to hear. And almost a third of the patients did have sensory neural hearing loss, so nerve loss in your hearing. And we had serial data for the ABR just like we did for the eye test, the ERG, but there was not consistent results. We did not see stable results. Some people got worse, some people got better over time, and there did not seem to be an effect of antioxidants one way or another. So looking at the hearing pathway, trying to look at that as carefully as I was looking at the eye pathway, I could not demonstrate that the antioxidants are actually helping the hearing. So I'm not sure how much these oxysterols, these toxic substances, are playing a role in hearing problems. There may be other reasons why people have hearing issues. And it's possible that things may be stabilized with the antioxidants and not get worse, but just not get better either. And I don't know if this test, this ABR test, is as sensitive as the ERG test and able to give me these results. So in the time I have left, I wanted to move on and talk about a new study that's about to begin for patients with SLO, and that is giving a bile acid medicine called cholic acid. So Dr. Rizzo knows very well how long this has taken us to get this up and running. Years, several, because of a combination of factors. But finally, we're at the brink of starting this. So cholic acid is a bile acid that normally lives in your intestine and helps you absorb fats. Back in the 90s, when the cholesterol problem in SLO was first described, cholic acid was available, and I used it in my patients. And it was well tolerated, and it helped me bring up the cholesterol levels and bring down the precursor levels, and it was fabulous. By the late 90s, the company making it didn't realize that people were using it, and they just stopped making it. And for 20 years, it was not available. So I had to use some other bile acids, which were not as well tolerated and maybe didn't work so well. So a few years ago, a new company called Retrophin bought out the rights to make cholic acid and contacted me and said, hey, would you be interested in using this with your SLO patients? And I said, heck yeah. So have been trying to get this protocol together ever since. There are a lot of hoops you have to jump through when you want to add a new medicine to a research study. And all the studies that I do are on a research protocol approved by the Investigational Research Board at my hospital. And so I can't just, as a doctor, do whatever the heck I want and put patients on medicines indiscriminately. That's against the law. I can't do that, especially when I'm dealing with children and especially when I'm doing with helping individuals who have intellectual disability, because there are very special protections that you have to make sure you're following the rules if you're wanting to treat children or people with intellectual disabilities. So we had to follow all of those rules, and I've presented to the safety board now several times and so on. So how the study is being designed is it will be a pilot study to show that cholic acid is, 1, safe, and 2, works. And we're going to use it for 8 weeks. And follow levels closely of cholesterol in the precursors, and also follow safety labs, particularly liver function, and make sure that I'm not doing anything that's going to hurt patients. I'm going to be able to enroll up to 15 patients whose cholesterol levels are less than 125 milligrams per deciliter. We're not going to treat babies because babies with SLO can be very, very fragile and sick, and I just want to make sure that children are sort of stable and in a better place before I start this. And we'll go up to age 25. And how we've written this protocol is that to start on it, we'll need to check 2 levels and prove that they are of cholesterol, and prove that they're less than 125 sometime within a month of starting the cholic acid. And then patients will be seen at a STAIR site. So STAIR is supporting this project. And so the STAIR sites that have agreed to participate, my site is the main site, but Nebraska with Dr. Rizzo, Cincinnati with Dr. Hybe, and Pittsburgh is the 4th site, I think, that might be able to do this. I'm not totally sure about Pittsburgh. And the idea will be, so 2 lab checks prior to studying, coming to a STAIR site, being seen and having a set of labs and an exam, and then safety labs drawn in between, and then at the end of this 8-week period, going back to the STAIR site and having labs drawn again, and then 1 more lab set of draws at, close to home at 4 weeks a month after treatment. And so the goals will be to show that the cholic acid is a safe medicine to take, that it's tolerated well, and that it will help the cholesterol levels go up and the precursors levels go down. So if this pilot study with a small number of patients shows that the cholic acid is safe and effective, then my future hope is that I will be able to use cholic acid in my patients with SLO, especially those kiddos who have very, very low cholesterol levels, that it's just really hard to get in enough cholesterol to bring their levels up so that they're more healthy. And that I would like to be able to use it in younger children because those are often the ones who need it the most. I plan to continue to do it in conjunction with cholesterol and antioxidants, but we will need to find a new funding source for this after this pilot study, because STARE is not going to be able to fund it in the future. So that was my last slide. I will stop there and take questions. Thank you. Okay. Questions? All right. Do you want me to go back?
Question on the cholic acid. It's still not available just to go pick up at the drugstore.
Correct.
Okay. And how soon are you planning the pilot study to start?
The hope is that it will start within this summer.
Oh,
I'm hoping.
great. So if we're interested, what do we do?
Send me an email.
Okay. All right. Very good. I also had a few questions back to the retinal study. The vitamins that you're now recommending, I
Yes.
saw you can actually order them on Amazon.
Yes.
Do you recommend taking the prescribed dose that's on the bottle? Okay.
So that's a good question, okay? The way I'm doing it, I'm trying to do it carefully so I can actually have data and to be able to follow patients and show that it's working. And I'm hoping that in doing it in that fashion as part of a research study, that I'll be able to see what dose eventually is the best, what vitamin is the best, to actually show improvements in the function of the retina. If you just, my heart says that vitamins are helping, but I still don't know which particular vitamins and the dose because I'll need to have better, easier access to oxysterol levels to show that the medicine is actually working for that, to lower the oxysterol levels. So my hope is that people will elect to do it in that more careful way so that we can actually learn from the data and be able to help patients in the future to better understand the right way to do it.
So if we have a mildly affected child whose retina is fine, even under the exam.
Under anesthesia with a good exam.
Yes. Would you not recommend we use those vitamins necessarily?
So has your child had an ERG?
I believe so. I'm going to have to double check.
Okay. So the question is, we saw subtle ERG abnormalities even in patients with normal vision, okay, and without significant pigment deposits. So it's possible to still see an effect on the retina even though it's not visually significant. So.
Okay, thank you.
Yeah.
Again, being the parent of an older child, with the eye exams and stuff, we basically don't have an ophthalmologist because we went when Ellie was younger and they watched. She does have cataracts in both eyes. They've not gotten bigger. They're not center vision, but they're just little pinpoint cataracts. She did show signs of nearsightedness but she won't keep glasses on, so there was really nothing they were going to do. And so the last time we went, they said, you don't need to come back unless there's a problem. Being a family that comes with bad eyes, it's a concern of mine of what she is seeing and what's going on there. So I guess what I'm wondering is there a way, is there somebody you can maybe recommend in our area for us to be able to see what's going on with this? And see if we can get in with somebody to get a more in-depth type thing going. And then I also was with that vitamin. Does it come in a liquid form for the kids that are tube fed?
Yes.
Okay. And then the last thing I have is with this study you're going to start, what was the reason for stopping at 25?
The bulk of the patients that I am personally following and that many of my colleagues are following are in the sort of pediatric age group, but I didn't want to stop at 18 because my patients were, aging out of pediatric age and into their 20s. So we kind of picked it empirically. It's just what we wanted to start. We had to start someplace, right? But my hope is that eventually, if we show that it's a safe medicine, that we'll be able to.
Because Ellie's last cholesterol was 23.
Ay.
So, yeah.
Yeah.
It's very low.
Yeah. So my antioxidant study is open and still enrolling patients.
Okay. Thank you.
All right. Thank you very much.